Hi, everyone. My name is Erica Bachter, and I am a National Program Coordinator here at the American Liver Foundation. And I'd like to be the first to introduce you to the monthly Life with Biliary Atresia and Beyond webinar series. We have a really great program today. The American Liver Foundation has partnered with the Cincinnati Children's Hospital on a few different occasions now, and we are so lucky to have Dr. Greg Tiao on the call with us today. Before we get started, I'd like to quickly go over a few housekeeping reminders. So first and most importantly, today's Life with BA and Beyond webinar series is being delivered on Zoom and will be recorded. And we would really appreciate if you could go ahead and mute yourself during the program, just to avoid any disruptions while our speaker presents today. And if you do have something that you want to share or have a question, please utilize the Zoom chat feature and share your thoughts that way. And we will have a Q&A section after Dr. Tiao's presentation. So again, please know that this program is being recorded and will be shared in ALF's private Life with Biliary Atresia and Beyond Facebook group for folks who might not be able to join us live today. I'd also like to take a moment to acknowledge our generous sponsor, Albireo, for their support of the American Liver Foundation's Biliary Atresia initiative. We are just so grateful for their ongoing support of this new program. So now we'll get into the exciting stuff. I will go ahead and introduce our featured speaker for today. Dr. Tiao shared his medical background, which I will go over shortly, but really quick, I'd like to share a little bit of information that he provided about his medical training that I just thought was too important not to share. So during Dr. Tiao's training, he cared for several patients with biliary atresia, and he noticed that patients with BA and their families have to go through so much in such a short amount of time, all with minimal understanding of why the disease even occurred in the first place. And he goes on to share that he decided to focus on the disease process, pursuing both pediatric surgery and transplant training so he could care for a child with biliary atresia from diagnosis all the way to liver transplantation if needed. And I just thought that information was too important not to include in Dr. Tiao's introduction, just because a child with BA has an entire medical team on hand to provide care. And the fact that Dr. Tiao chose to focus his training specifically to care for a child from diagnosis all the way through transplantation, I feel just really speaks volumes to his dedication to his patients and to his practice. And it's just beyond amazing. So now I will go ahead and actually introduce him. Dr. Tiao is the Director of General and Thoracic Surgery and Surgical Director of Liver Transplantation at Cincinnati Children's Hospital. He holds the honorary chair, named after the founder of the liver transplantation program, Dr. Frederick Reichman. He is a pediatric abdominal transplant surgeon with a focus on hepatobiliary disease, pediatric surgical oncology, and solid organ transplantation. And while working with patients has been a major focus, he has also established and contributed to bench and clinical research programs, developing new treatment strategies to improve outcomes in the care of children affected with chronic liver disease and liver tumors. Dr. Tiao, thank you so much for giving us your time today. I will now go ahead and hand over the program to you.
Thanks. Let's see, I should share my screen now, right? Okay. Thank you, Erica, for the very, very kind words. Actually, another way to look at it is it took me 12 years after medical school to finally get a job. So that's the actual corollary to a lot of that training here. But really, it is a privilege for me to be here. And biliary atresia is a disease that I have committed a fair amount of attention to try to contribute. Unfortunately, I'm not that good at it because we still haven't solved the disease in a way that will alter the end result of so many of these kids still requiring liver transplantation. But that's really the goal of my research team, along with Dr. Georgia Bizzarra here in Cincinnati. We've been focused on this disease process. Dr. Bizzarra has made some interesting findings in terms of making the diagnosis We have some models that have characterized how the liver responds, and hoping to bring some of those things to the bedside in the not too distant future. But really for today's seminar, webinar, I just want to give you some thoughts for people who are a little bit, getting exposed to it. And again, for all the people who have kids with biliary atresia as a new diagnosis, I so wish you guys didn't have to deal with it. It's not fair. It's not right. The reason we do the research here is to try to change that trajectory. And what we can say is we can give these kids a very long-term survival and a normal life, but it comes at the expense of a lot of interventions that many people never have to think about in their lifetime. And so that's why we do the research that we do here, to try to alter the course so that maybe the kids might not need it. We haven't dented it to that degree yet, but we're trying pretty hard to do so. But really, I'll transition now to my slides here. And as Erica mentioned, our goal today is to give you a little bit of a sense of what happens once you have the diagnosis of biliary atresia. What does a Kasai mean? What does liver transplant means? And again, I look forward to answering any questions that people may have. It's real easy for me to get onto a spiel here because I've been doing this for a while. And so please send your questions through the chat, and we'll be happy to answer them either at the end of the conversation or certainly by email down the road. So what is biliary? Oh, so I'm sorry. So these are some of the questions that we hope to answer in today's webinar. Erica was kind enough to share these with me. And so this is the list that she sent, and I have them listed on the slide here. And at the very end, I hope I'll have abbreviated answers to each one of them. But over the course of the next 20 minutes or so, we'll try to touch on various aspects of these questions. So patients and families, well, patients are too small at this stage, hopefully, but families understand what are the pathway, what's the pathway, and what are the challenges that people will be encountering as they navigate this journey here. So what is biliary atresia? So biliary atresia is a diagnosis that was established long ago, but it's an inflammatory cholangiopathy, and that's a big medical term for basically some sort of immune triggered process causes the biliary tract. And the biliary tract is how your liver makes bile, and your biliary tract is how the bile gets out of the liver into the intestines. And for some reason in kids with biliary atresia, it scars down, it becomes basically obstructed or obliterated. And that in turn triggers a series of changes within the liver, causing it to become scarred and develop what we call cirrhosis, which is basically a scarring fibrotic process where the liver develops multiple little nodules. And I'll show you some pictures of what that might look like in a second here. And unfortunately, it was first recognized in the 1790s, but and for years and years and years, there were no good treatments. And without treatment, unfortunately, all of these little people would succumb to the disease. And so this is where there have been some tremendous advances in the last 50 years, one of which is the Kasai, the second of which is liver transplantation, and we'll touch on those here in the next few minutes. So like I said, it was first diagnosed a long time ago, 1890. I said 1790s. That was a little decade, a century apart, but it was 1890 where a pathologist first recognized an obliterative process. The term biliary atresia got established in 1916. And then Dr. Ladd, who was actually the founding father of pediatric surgery, described a correctable form of biliary atresia. And I'll show you what that means in a second. Dr. Morihito Kasai was a surgeon in Japan who in the 1950s first started thinking about this disease process. And he did a whole bunch of analyses trying to understand what was going on in livers. And he just started to describe this obliterative process. And he proposed this procedure called the portoenterostomy. And it's been named after him, the Kasai portoenterostomy. In the 1980s, liver transplantation evolved from very much an experimental process to something that has now become the standard of care. And unfortunately, I think in this day and age, we warn all families that even if you have a successful Kasai, most of the kids will still develop a progressive liver disease. And this is what's been found in the Japanese biliary atresia research registry, which was started by Kasai. Originally, we thought that a proportion of patients might live their whole lives with a native liver. But what we found and what that registry has found is that as the patients get, even who had a successful Kasai, that ultimately they'll develop chronic liver disease to the point that they require transplantation. And so this is where families do have to be ready for transplantation to be part of their journey here. So the challenge with this process is that really many times the children look quite healthy as a newborn, and then they develop jaundice. So that's where their skin and eyes look a little bit yellow. Many children will have what we call physiologic jaundice in the newborn. This is a developmental abnormality in the liver where its ability to conjugate bilirubin from indirect to direct is a little bit delayed. And that's why it's incredibly common for kids to have this physiologic jaundice. This is where families will switch formulas. They'll be out in the sun. They'll use bilirubin lights. And many of those children the jaundice will resolve. But if the jaundice persists, that is when a workup is critical to be done, because the sooner you can make the diagnosis of biliary atresia, the sooner we can intervene with a Kasai pointorostomy. That's what some people will call the golden period of diagnosis, where you try to establish that diagnosis. On occasion, some of these kids have other associated anomalies, and I'll show you one of the more dramatic ones. This is called the polysplenia syndrome or biliary atresia splenic malformation, where they actually have multiple spleens, an intestinal abnormality where the intestines aren't in the right spot. They also have a way that the liver drains blood from the intestines that a little bit different. They have a preduodenal portal vein, and they have some other congenital heart issues that can be a significant challenge. But again, the general situation, there are 90%, 80% to 85% of the patients are healthy who then suddenly are noted to be jaundice and a workup is initiated. In North America, the incidence is estimated at 1 to 15,000. In the Far East, it's a little bit more common where it's 1 in 10,000. And so this is where studies have been ongoing in all of the respective countries for years, because it is the most common reason for kids to have to go through a liver transplant. So when you first get diagnosed with jaundice, your pediatrician will ideally send you to a gastroenterologist, a GI doctor, a pediatric GI doctor, many of who focused on liver disease, and they'll start some blood tests. And so what they'll do is they'll get blood tests that include your bilirubin levels and how your liver is working. So there's some liver enzymes. They'll test for some common other reasons that can cause jaundice. This includes some infectious issues, such CMV, hepatitis, but also the torch titers, that's toxoplasmosis, rubella, congenital CMV, and some of the hepatitis. And the herpes viruses can all cause your liver to be a little bit jaundiced. In the modern era, and I say the modern era, over the last 20 years, molecular profiling has been established where you can take blood samples, you can send it off to special labs that will end up studying that blood for any of the known defects that cause jaundice. And this is where the field has really evolved substantially over the last 30 years. 30 years ago, many kids had what we call indeterminate hepatitis, where they had a jaundice process, but they didn't know what the etiology was. But over these last 30 years, a whole series of diagnoses have been established, everything from progressive familial intrahepatic cholestasis, Alagille's disease, then alpha-1 antitrypsin can cause this disorder, cystic fibrosis can cause jaundice. So all of these things can now be studied at the molecular level. Unfortunately, some of these profiling studies take days to weeks to get done. And so this is where a delay can occur if you're waiting for these results. And this is where some of these other interventions become central to the process. But if you have a child who's jaundiced, you're going to get these studies established. And then very recently, or in the last 4 or 5 years, Dr. Becerra actually found this protein level of this matrix metallic proteinase 7, which can be elevated in biliary atresia kids. And so it's actually become a really important tool in terms of an earlier diagnosis, because waiting for some of these other tests to get done will take weeks to even months, whereas this can be done and turned around in a day. On top of it, the kids will get an ultrasound. An ultrasound is basically where they take a microphone, put it against a baby's tummy, and will send sound waves in, and it comes back to the microphone, and that's how they reestablish an image. And from that, they'll look at the gallbladder for other reasons. For biliary atresia kids, oftentimes the gallbladder is scarred, very small. They'll see some findings that are sometimes consistent with biliary atresia, but it's not a perfect study. It's used more to rule out other reasons that kids are jaundiced. Then if these studies are suspicious for biliary atresia, kids will go on to get a liver biopsy in some centers. Not all centers will do this, but some of the centers that are tied to more, who focus on this disease process will oftentimes get a liver biopsy. And then finally, if this is consistent with biliary atresia, the kids go to the operating room for the first step of the next step of evaluation, which is a cholangiogram and a biopsy. And I'll show you some pictures of what that means here in a second. But this is just an example of a liver biopsy. So this is normal liver over here. People ideally can see my cursor here, but this is normal liver in the screen's left upper quadrant. This is the portal triads where there's been proliferation of bile ducts. These are all bile ducts. And the pathognomonic finding of biliary atresia is what we call a bile plug. So a very experienced pathologist can help us establish the diagnosis of biliary atresia, and then we go off to the operating room for this intraoperative cholangiogram and also a Kasai if it's indicated. This is an example of a patient who actually has one of the less common abnormalities for a biliary atresia, where you're actually having a catheter. We put a little IV into the gallbladder. The gallbladder actually is open. It was full of white bile, and we inject contrast into it. And this is your bile duct going down into your intestines coming across here. This is the duodenum. This is your pancreatic duct coming across the side here. Hopefully people can see my arrow. But what they're actually showing is that the main bile duct is open, but we could never get contrast to go up to your liver up here in this area here. And so this was actually a patient who had biliary atresia. And this is what I mean by the subtypes of how the bile ducts can be obstructed. This was actually a descriptive classification made by Dr. Ohai, one of Dr. Kasai's proteges, where they describe where the bile duct is obstructed. And type 1 and type 2 bile duct abnormalities are where the common bile duct is blocked. Sometimes they have cysts in it, and this is what we call the correctable variant of biliary atresia. But the most common is the main bile duct, the gallbladder is all blocked, and into the liver itself, where the bile ducts, the left and right bile duct come out of the liver, is a fibrous cone of tissue. Now they have some other variations to this, but I'm going to I don't have time to touch on all of those here, but they are relevant in terms of how often we think a patient might drain. So once you've established the diagnosis of biliary atresia, then there are two treatment options. Unfortunately, at this stage, there's no medical treatments that can prevent the need for a Kasai port neurostomy or a liver transplantation. And so that's really where surgery is necessary for for kids at this stage. And really our goal is first to offer the Kasai, because many infants will get a pretty good response, and we'll talk about outcomes here in just a second. But if they get a good response, it could certainly delay transplantation until the kids are much older. And that's really the goal of this procedure. It's rare for us to offer a surgery and say, hey, it only has about a 70% effective rate, but we're going to offer it anyways, because the other choice is to do liver transplantation when kids are very small. And that's asking a lot. It puts the kids through a lot. They can tolerate it, but it's still a lot for them to go through, whereas you might buy them years and years with the Kasai. So the sequence of interventions that are offered are a Kasai port neurostomy first, if it's feasible and the liver can still be salvaged. And then if the liver is already progressed or develops more changes, transplantation then can then become necessary. And I'm going to touch on both of those things in these next few minutes. So the Kasai port neurostomy, as I mentioned, was described by Dr. Kasai in the 1950s. When it was first introduced in North America, it met a lot of resistance. And that's in fact why Kasais weren't really offered commonly in North America until the 70s and 80s. And that's when people realized the other options that had been devised really were not effective. And this one had an effective rate that actually warranted its intervention. And as it was developed, there were a lot of different variations, but it's really been now standardized to a procedure that I'll show you in the next second with a few pictures here. And so this is the steps to a Kasai. So now this is a little baby who's going through a exploration. His head's over here. This is his liver here. And so this liver, I just highlight for you, is a little bit more brown than it should be. You can't see it, you can't mag up on it, but it's got some nodularity, and I'll show you some pictures of it in a second here. This is the gallbladder, and we took it out of the fossa, which was underneath this retractor here. And this is the blood, what we call the portal triad, which is taking the bile duct where it should be, the artery here, and underneath it is the portal vein. And so this is what we'll typically see where we see some changes here. We had already done a liver biopsy at the time of this because we were pretty sure this patient had biliary atresia here. And so that's the first step. We dissect out the gallbladder. Now this is a higher magnification, and now you can kind of get that sense. It's not exactly in focus, but you see this nodularity to this liver. This is now that gallbladder going into where the bile ducts are supposed to be. This is the hepatic artery, the right and left branch here. Here's the portal vein, and you see this cone of fibrous tissue here. This is where the liver, the bile ducts have scarred down into a cone of fibrous tissue, and it can't actually get bile out of the liver. And so what we do here then is we cut that cone out and we leave this fibrous remnant here. You see, this is the artery, the right artery here. This is the right artery here. Here's the portal vein going down underneath this area here. And so this is the remnant of where the liver should be draining bile from the liver itself. You see, it's not exactly an ideal operation because we're really dealing with scar tissue. Usually when we start talking about connecting intestines to another structure, we want to go what we call the innermost lining mucosa to the mucosa of the bile duct. And there's something called choledochal cyst, where if we cut a choledochal cyst in this area, you'd see a circle with 3 layers of tissue to it, the mucosa all the way out to the serosa, that we would then be connecting to it. But this is where a Kasai procedure is really, we're cutting away the scar tissue. Within it are tiny little remnant ducts that we then bring up the intestines to and drain in that whole area. And that's really the procedure of a Kasai, where we've rerouted some intestines, we've brought it up to this remnant bile duct area, and we've anastomosed it to that scar tissue. And then by some kind of really amazing recovery, the liver forms connections through that and actually can drain. And this is what we look for from a successful Kasai standpoint, which is this operation is kind of this connection, but then we see how the kids respond, and what we do, we go into the monitoring and recovery period. So this procedure typically takes us 3 to 4 hours at the very most. It's a very standard operation that's now done. Kids have a little NG tube in to decompress their stomach for a few days. They'll have a catheter in their bladder for a couple of days. They don't typically go to the ICU. They're typically on the floor. In a matter of 3 or 4 days, they're ready to get out of the hospital, because kids are really resilient. Babies are really resilient. If this is me going through an operation like this, I'm limping for at least a week, and I'm in the hospital for, I'm limping for at least 6 weeks, but I'm in the hospital for a week. Kids, we oftentimes can get out of the hospital in 3 or 4 days here. And so this is just a picture of what a polysplenia patient looks like for biliary atresia splenic malformation. This is what we mean. A spleen is normally a solid organ, and this patient has multiple spleens. And this is where that portal hilum was so different. This patient had a pre-duodenal portal vein. You can't see it underneath here, but the hilum itself that we were just describing was over here. And so this is where these kids tend to have a little less successful drainage rate, because there's a congenital abnormality in terms of how their liver developed. So that's, and then there's also this thing called the cystic variant of biliary atresia. These are the different types of biliary atresia that we'll see: the biliary atresia splenic malformation, the sporadic, and then this is a correctable variant. And this is where nowadays, because so many moms are getting in utero ultrasounds of the babies, there are kids who are diagnosed with a cyst in the hilum of the liver, and this is where we sometimes will see correctable variants of biliary atresia. And this is a critical population for us to stay on top of, because if we can intervene before 30 days of age, they have a much better long-term drainage rate. And so this is just an example of another cholangiogram where we're injecting dye into this, and you can see this cyst forming within the liver. Then you see these little tiny remnants of stuff draining out of the liver. And this is where we can sew our Kasai right to this area here, and we can anticipate that these kids might drain a little bit longer. And in fact, this little girl is now like 5 years out from her Kasai and still draining. So what's the post-operative management? So they have those tubes that I mentioned. Within a matter of days, those tubes are starting to come out. Then what we try to do is optimize our nutrition. And this is where we're partnering with our GI collaborators, our hepatologists, where we're going to optimize their nutrition. Many of these kids do require supplemental feeds to help their liver kind of recover from the stress that it's been through. They'll also be on fat-soluble vitamins, because when the liver's not draining bile, it doesn't absorb nutrition as effectively. The fat-soluble vitamins are also oftentimes low. So that's one of the critical things that families can help the kids recover with, by optimizing nutrition. We try to prevent infections from occurring within the liver. That's what we mean by cholangitis. And many of these kids will be put on Actigol, a stimulant, a bile acid precursor that we'll use to help improve the bile flow. And then there were some studies that were done that looked at the role of immunosuppression or anti-inflammatory agents. This is really steroids, and on occasion reoperation. But I'm not going to touch too much on this. I'm just going to hit on the immunosuppression real quickly here. But so in the recovery period after Kasai, what the teams, our surgical teams, are going to be looking for is they'll be monitoring diapers, and basically we're looking for the pigmented stool. So as many people who've had kids with biliary atresia have realized, what they had for those first couple of months of life is really very white appearing stool, and that's what we mean by acholic. After the Kasai, the people should have stool the color of my scrubs. I don't know if people can see it, it'll turn green. And that's when the surgical teams do a little bit of stool dance here where we're super happy if it's green poop. And that it's kind of weird for families to say that, wait, you want me to save every diaper? And the answer is yes, because we're looking to see the stool become pigmented. Then from a blood test standpoint, we will get liver tests, but usually we're really not paying that much attention at the beginning because the liver will take a little bit of time for it to successfully drain. So what we're looking for is around 2 to 3 months after the Kasai, the bilirubin level dropping below 2. And if that happens, then that is when you can consider a successful Kasai. Now, our Japanese colleagues are super capable and super smart. And so they came up with a way to help families monitor how their kids are doing. And this is what we call stool cards. And this next picture is a stool card that our team got from one of the Japanese team and have actually utilized for our patients, where this is a scale. So this is not good. This is bad. This is gray poop. We're all unhappy. This is green poop. This is the pigmented stool that makes us all happy. And so if you're someplace between 5, 6, 7, we're generally saying, okay, it's working. 4, we start to get uneasy. 3, we start to say, bring them into the hospital and consider some antibiotics and, if necessary, some additional steroids to see if we can convert them into more colored pigmented stools. And this is where our Japanese colleagues are very aggressive about keeping kids in the hospital around the procedure, but also utilizing steroids and antibiotics. And this is what actually prompted a study that we did based out of Cincinnati, and I'll talk about in just a second here. All right. So this is kind of where we're now sending families home with a stool card. Some teams are even smarter where they actually have put it on an app and they'll have the families work on that. And that's something that we're trying to get around to doing because, again, in this day and era, everybody has a smartphone and they can do that. But we'll send the families home with a stool card, and then we'll ask the families to send us a picture of their poo. Some families send it every day and we're fine looking at it, but it's one of those things where we're trying to stay on top of the pigment of the kid's stool. And if it starts to head in the wrong direction, that's when we sometimes will bring the kids back to the hospital. So how does this all result, or what's the impact in terms of outcome? So what we're really trying to do is establish bile drainage without a progression to end-stage liver disease. And what people have found over time is the one biggest factor of overall things, this goes to that golden age or golden period for diagnosis of biliary atresia, is the age at intervention. And what people have actually realized, and I say people, research teams across the world have established, now, this earlier that you can get a patient to a Kasai, and when I first started 20 years ago, we were happy if we got a patient to a Kasai by 60 odd days. But now we're trying to push the window down to 30 days, because if you can get it even 30 days, you have a better chance for the Kasai to be durably drainage. Our European surgeons showed that experience and operative technique of the surgeon matters. And this is where more experience is helpful. What they found in a study from the UK was in centers that did more than 5 Kasais a year compared to centers that did less, the outcomes were 40 to 50% better. And this just goes to volume and outcomes comparisons. Teams that are experienced do have more knowledge on how best to optimize the outcomes. And so the end result is that the cases do better. Now, at the pathologic level, you can actually look at the size of the bile ducts in the triad, and then you try to prevent complications, including cholangitis, and all of those things will help your liver drain longer. And this is also where I mentioned the biliary atresia splenic malformation. This is what we can call congenital variant. These kids tend not to drain as well as the acquired. Sometimes these kids have congenital heart disease, so it makes it a little more complicated here. So I touched on this a second ago as to whether we should or shouldn't use steroids. And this is where this slide here, people can kind of look at in the subsequent, when you have a chance to review the presentation, but it's been widely used in the Far East. And it's a study, they were all retrospective in terms of how they proved that it was helpful. And so a couple of prospective trials were designed by our colleagues in England and Germany, and they didn't really found it to be super effective. So Dr. Becerra here, along with our team here, put together a trial that was actually run by the Children's Network. Children is the Childhood Hepatic Liver Disease Research and Education Network. It's sponsored by the NIH. It's right now 14 centers who are contributing to that effort. And what they did is they came together and agreed to do a prospective trial comparing 70 patients in each arm who received either high-dose steroids or no steroids. And what they looked at was the clearance of jaundice, as I mentioned, a successful Kasai at 3 months. And what they found was that despite pretty good size dose of steroids, it didn't seem to impact outcome. Now, there's a lot of caveats to this study that is still being explored. But right now, as a principle, this is evidence-based to say steroids are not helpful. Now, there are some populations that we're exploring as to how, if it is beneficial, but that kind of effort really should be done in centers that have experience in terms of utilizing steroids long-term, because there are some small risk of side effects from that process. This is kind of just a table listing what we expect in terms of outcomes. This was from our Japanese colleagues. This was from the UK. BARC became the Children's Network. This is from our European colleagues, France and England. And what they're looking at, the median age at which go back a slide. But what they found was the age at which many of the Kasais were being done were in the 50s to 60s. So back at this point in time, not bad. And this is what they would expect in terms of how long the native liver would survive out to 5 years. It was 50 to anywhere from 30 to 50%. But then when you added in transplant, you could achieve pretty favorable survival rates of 90+% in the best of hands. And nowadays, what we're really seeing is a shift to getting these Kasais done even earlier and earlier. But when I'm talking to a family, what I'll generally just frame for the families is a lot of these are nuances. And what we'll generally say is about a third of the kids will have long-term drainage. This is where they'll be draining into their teens, maybe even into their 20s and 30s with their native liver still in place. About a third of the kids will get a good response, but then end up developing progressive liver disease and require transplantation in childhood, early adolescence. And then unfortunately, about a third of the kids will not get a response in at all and require transplantation before they're 2 years of age. And so that's just kind of a way to think about things in a broader standpoint, not to get too caught up in the individual studies and nuances of the studies, but just to realize that we're really hoping to get about 60 to 70% of the kids out of infancy without transplantation. And so that's the way we think about Kasais. So clearly, that's not very good here. So even in people who are thinking about it all the time, we still have a lot of things to figure out from school here. And so this is where liver transplantation has been integrated into this process. And unfortunately, or depending on how you look at it, biliary atresia is the #1 indication for pediatric liver transplantation. It's the smaller kids that really drove a lot of innovation in liver transplantation. It actually is what caused the development of what we call technical variant grafts, reduced size grafts, and living-related transplantation. In the next few minutes, I'll touch on each of those things here. So what are the indications for liver transplantation for a patient with biliary atresia? So there's some kids who fail their Kasai completely, and they'll develop progressive liver decompensation, manifest as everything from ascites to worsening jaundice. Their synthetic function will go down, be unfavorable, where their albumin levels will drop, their clotting factors will become abnormal. They'll develop portal hypertension. What we mean by that is when your liver is cirrhotic or fibrotic, blood flow into the liver meets resistance. And so those blood vessels, that blood tries to find other ways to get around the liver back into the circulation. And that's where the process of varices can occur. And varices can then in turn bleed. And that's what we call the hemorrhage from a portal hypertension. When a patient is doing this is when they really have to be very high on the transplant list because they need to get transplanted soon. Now, some kids with a successful Kasai, so that means their bilirubin has corrected, they'll still over time develop progressive liver disease, mostly manifest as portal hypertension. Some kids will have recurrent cholangitis that will cause more liver disease. And then unfortunately, some kids are at risk of developing liver cancer within a cirrhotic liver. And so this is where even with a successful Kasai, the patient has to be monitored closely by our GI colleagues, our hepatologists, who will track these kids. All of these kids will be getting a yearly ultrasound and AFP level to make sure this doesn't develop, and they'll be monitored for some of these other changes. And so just as a kind of one other component that some families will ask is, if the Kasai doesn't work, why should we, and at least a third of the kids, should we just go straight to transplantation? And the answer to that is, and this was addressed in the 90s, and it's actually still being discussed at times here, but realize there are more people on the liver transplant list than livers that come available. So there's a donor shortage. And it's actually a pretty complicated procedure, much more complicated than Kasai. And so if you can have some kids who really get a great response, which means they're going to stay away from transplant into late adolescence, early adulthood, then that's why there's a rationale to offer the Kasai first. And so this is the way most programs now approach it, which is you get a Kasai first. And if you develop the signs of a failing liver, that's when manifests as cirrhosis. That's when you go on to transplantation. But unfortunately, some kids do present so late that they already have advanced changes in the liver and primary transplantation becomes warranted. And so that's where there's some nuances to a care with a patient with Atresia. But the critical first one is to see if the kids can be diagnosed as early as possible. All right, so this is just an example that my senior partner, Dr. Eichmann, actually took long ago of a patient with a failed Kasai. You can see he hasn't really grown very well. He's got his fluids are all kind of jaundice stained. He's got ascites, so his liver is real big, and you can see how small he is. This is Fred's watch, and so this is the type of situation that prompts us to put a kid through a liver transplantation. And so one of the questions was, okay, what are the different types of grafts that we use? So our first and most preferred choice is what we call a whole organ or a size match graft. And that's typically a donor who's about 25 to 125% of a recipient's weight. And this is what we'll use for a whole organ, where the whole organ goes into the patient. All the blood vessels are the main blood vessels themselves, and it's the most technically straightforward procedure that we'll do. But the frequency of donors especially for our infants is fortunately low, right? We don't want kids to suffer irreversible brain injury and pass away when they're infants. And so this is where society protects them. And so the end result is the frequency of whole organ donors is actually quite small. And so this is where technical variant grafts got developed to address this the inadequate number of whole organs. And there's both deceased donor and living donor alternatives. And a deceased donor, someone has sustained irreversible brain injury, and then we can do surgery on that liver and reduce it, which the other portion is not used, or split it where two grafts can be made for it and two patients can be transplanted. This is our preferred approach. And this is the types of grafts that we'll get: a left lateral segment, an extended right lobe. This is the typical procedure for our infants with biliary atresia. And then sometimes we'll use what we call a left lobe, right lobe split. I'll show you some pictures for that. But when surgeons started to figure out how to do this technical variant reductions, we realized that we could actually do that on living donors. And that's where a living donor, a healthy, typically family member, but it can also nowadays be an altruistic donor, will donate a portion of their liver, left lateral segment, most commonly used for kids, a left lobe utilized for older kids, pre-adolescent typically. And then we don't have to do this typically in our patient population, but if you go to an adult center, they're very commonly using the right lobe, which is a much bigger operation where an adult is giving to an adult in that context. And these are pictures of what I mean by that. So now this is your whole liver here. Now it's being split into a segment 2 and 3. This is a left lateral segment. This is based off anatomy of the blood vessels. And you can see here's an artery bringing blood up to the liver. Here's the portal vein. Here's the hepatic vein. So those are the structures that we have to think about when it comes to transplantation and reconstruction, because all of these blood vessels have to be prepared in a way so that we can then implant them on the recipient so that this liver stays healthy. And if we're doing this is where our team might be using this, and an adult team would then use all of the rest of the liver for an adult recipient. So this is where transplant teams will partner with each other, and some centers will actually split with themselves. And so that's where they might have, if they're adult surgeons who do pediatric transplant, they may have adult partners who will use this, and the pediatric team will use this. This is the right lobe, left lobe split. It's a little bit more complicated operation, and there's a variety of ways that the hepatic veins can be reconstructed. But this is where you'll take a liver and split it into a left lobe, where we're now including segment 4 of the liver versus the right lobe. And then there's different ways that you can manage the vena cava for the outflow of these livers. And so that's where the surgical teams are working together to try to optimize the utilization of every person who has done something heroic where they've passed away, and then they and their family have donated their organs to society. Now, this is a little bit of, a different cartoon just showing you that when we're using these things, we actually have to prepare these blood vessels, the bile duct, the portal vein, the artery, and the vena cava outflow in a way that can be reconstructed for the patient. And so this is where the liver transplant is a technically challenging procedure, and you want to work with teams that are pretty experienced in terms of doing this process. This is just what a liver looks like when we're actually reducing it. And so this is a left lobe graft. This is what, if you guys think about the pictures I showed earlier about what a Kasai, a biliary atresia patient's liver looks like, this is what a normal liver looks like, nice, smooth, and soft. This is us dividing the parenchyma of the liver so that this left lobe could be used for recipient. This was a smaller donor, so this went to research instead of being utilized for another patient because it was just too small for that kind of patient. But this is what we mean by the technical variant grafts being utilized for kids. Now, the complications after transplant, this is just a laundry list of these many things, and I'm not going to go into each one, but these are some of the challenges that arise because a transplant is not a subtle intervention. It's kind of a miracle in some ways when you think about liver cells not seeing blood for several hours and then turning back on once blood is restored. That's what we mean by primary non-function, when those liver cells don't wake up. And then blood vessels can clot. Those blood vessels I kind of showed you that we have to prepare for reconstruction. You can form a clot in your artery, your vein, or your outflow, all of which can lead to that graft not working. You can have bile duct issues where you can have just a connection of the new liver's bile duct to the patient's native bile duct, or most kids with atresia to the Kasai roux that was created. And there can be some narrowings that can occur. And then there are very common surgical complications like bleeding and intestinal perforation. So this is where all of this makes a transplant pretty darn complicated. And then long term, this goes to why we try to offer a Kasai whenever possible, because once you've been transplanted, it's a lifelong commitment. Your immune system is altered. And you're on medicines that try to balance rejection versus infections. Rejection sounds scary, but it's actually very treatable in this day and age. We have so many more medications to do so. But if we completely eliminate rejection, we'll lose kids to infectious issues. And so that's where this is a balance. And then being on these medications have long-term complications. It can cause kidney injury, high blood pressure, diabetes. And then none of this is normal, so that the impact on kids and families in terms of the psychosocial is just something that sometimes it's very hard to fathom until you're going through this. And this is where teams have now put in place support to help families navigate this, because it's such a challenging process. And so what does this actually translate to? This is just an example of our transplant outcomes depending on the type of graft we use, everything from whole to split. This is for our patient series as a whole. When we look at our biliary atresia outcomes, it's most of the challenging outcomes occur in the first few months, where that's when kids get into trouble and don't survive. But once we get them out 3 months, the curve is pretty flat in that 90+% survival rate. And so this is what we mean by it's a lot to ask the kids to go through this. They're going through a Kasai and then a liver transplant. This is a slide Fred made 20 years ago, 25 years ago, and I still use just as a reminder for a patient who has biliary atresia. So if you had 100 patients with biliary atresia and go through a Kasai procedure, a third will have long-term survival and maybe get into over 10 years, and they'll still be living with their native livers. 2/3 will end up eventually needing transplant, some of whom might not get transplanted because there's not enough donors. But of those who get transplanted, the survival rate now is probably closer to 90+% for biliary atresia, 95% for biliary atresia at 3 and 5 years. So the numbers impact you like this. So this is where, despite all the efforts that have been going on, we're probably pushed the outcomes to probably 95 or 93% patient survival at 10 years, but it's still a lot to ask the patients to go through. And it's still not perfect because some kids never get transplanted or don't respond in a way that's favorable. And so that's the way we kind of look at biliary atresia. Here are the short answers to the questions for today's webinar. I'm coming from the top. So what are the possible outcomes? I just use this as just a frame of reference in terms of for families just to think about stuff, where a third will get long-term drainage, but these people still typically are requiring transplant when they're in their 20s and 30s. A third will get a good response, but will be transplanted before 18, and a third of the kids end up needing transplanted before age 2. A Kasai is successful when we see pigmented stool or the green poop. Some of the complications from a Kasai are cholangitis and progressive liver disease. Typically, you're in the hospital 5 to 7 days, a few days with those different types of tubes. We have to optimize your pain control, and then the kids are out of the hospital. Initially, you're going to, after Kasai, you're going to be seen pretty frequently by your surgical and medical team. But once, if there's good drainage, visits start to get spaced out. We see some kids on a yearly basis, and the families are vigilant. They know what to call us for if there's an issue. Yes, the gallbladder is removed because that's oftentimes scarred. The golden period is establishing the diagnosis of Kasai before 10 weeks of age. That's now getting late. We're really hoping to move that process to sooner and sooner. And there've been studies done in both the Far East and in the North America where they can identify patients at an earlier and earlier period so that the Kasai gets done at earlier age. These are the types of liver transplant organs that are used in terms of the types of graft. It's a major procedure and close monitoring is necessary for the side effects. And then we touched on some of the complications. And this is an example of Dr. Reichman's, one of Dr. Reichman's pictures also from a while ago. This is a young lady. This was when she was about 15 and she had her Kasai done when she was a baby. Unfortunately, when she got to 19, we ended up having to transplant her. So it again is one of those things where we want to give these kids normal lives, and she continues to have a normal life, and understand that after a liver transplant, people continue to do regular things. We have multiple kids who've gone through a biliary atresia and transplant who now have gone on to college, have gone on to have kids. So it's a lot to ask for, put the kids through, but our goal is to try to give them as much of a normal life as possible. And with that, I, of course, ran long, so I'm open to any questions that people might have.
Thank you so much, Dr. Tiao. Your presentation was just so detailed and informative, and I feel like this webinar will be a really, really helpful resource for families, with a new diagnosis, especially, wondering what to expect and what, that journey is going to look like. So as he said, I know he kind of covered a lot of our questions, but if anyone has any other questions that weren't covered, please feel free to write them in the chat, or you can go ahead and unmute yourself.
I have a question.
Sure.
Hi. So my son was transplanted. I'm actually with him right now. Sorry. He's kind of
That's good. That's good.
We're still actually in the hospital. He's been here for 5 months. He was transplanted right before a year old, and everything was going great, but he ended up having the portal vein thrombosis, and they thought he was going to need a second transplant, but luckily the liver labs are looking great. I mean, he has portal hypertension now, but they're just kind of like hopefully letting collateral veins grow is what I was told. And maybe as he gets older, if the labs, the liver holds up, we could maybe go into IR. And I know you can't stent the vein, but maybe do other procedures. What have you seen?
So
what's like the prognosis? Yeah.
Sure.
Sorry. I'm all over the place. Sorry.
Yeah, no I'm sorry that you're going through the challenge. Sorry that
it's crazy. 5 months in the hospital.
There's nothing normal about what you've been through, or your little person's been through.
And he's like weird for like the Kasai kids. Like everything that's gonna happen has happened. It's like crazy.
I'm sorry.
Oh my God.
Been there.
Yeah, many families have navigated pretty challenging courses. We've had our share of challenging patients, so none of this is easy, and all teams are working to try to be effective. But portal vein thrombosis probably occurs in about 1 to 2% of liver transplants. So any team that's done their share of transplants are going to have kids with portal vein thrombosis. Now, the good thing, just as you described, is the liver's hanging in there, so that's great.
Okay.
He probably is going to develop some more variceal risk. So
that's what is going on. They saw some more varices, so they're giving him a beta blocker, hopefully to lower that pressure.
Yeah.
Sorry guys. Yeah.
That's a very common intervention, especially in adults. But there's also reconstructive options for vein thrombosis, where there's something called a mesorex shunt, and it varies.
I heard about that.
Whether that's possible, but it was actually described for liver transplant patients in like 1989 by in Europe, and it's actually become, a very, common procedure. It's done for kids with normal livers who thrombose their portal vein also, but then for pediatric transplant programs, we've all had our share of kids. We've probably done 25 plus mesorex shunts for kids for both spontaneous portal vein thrombosis, but probably a handful of those are liver transplant patients. And so it does vary. And again, I don't know the anatomy of your little person's transplant.
Yeah.
That is certainly an alternative. Retransplant sometimes does become necessary, but you can also create alternative ways to kind of decrease the pressures in that portal vein. So there's a lot of options that are out there for teams. And again, every transplant team is going to have them on their kind of docket of treatment.
Yeah, because like right now he's so little, like if he could just get bigger, I think sounds like there's better options. He's still on Lovenox and they're going to scan him in a couple weeks to see if anything has opened up. But right now I see his albumin still like 3.1. And I mean, that kind of tells me maybe it's not open yet. I don't know. I'm just like hanging on to hopefully not another transplant, or at least let him get bigger and get out of the hospital, or I don't know. So I'm like, I guess it kind of depends, but you've heard this, and he hopefully can maybe come out of this.
No, it's scary to be going through this, but portal vein thrombosis is very different. So there's after a liver transplant, if the artery clots, then the kids will end up having very similar to biliary atresia like changes in their liver, and those kids all have to be retransplanted.
That's what they said. They said the artery is great.
So then that's why the liver's staying healthy. And so that's where it's still working. And so, yes, a little bit of time, a little patience, but the portal vein, there's lots of reconstruction options. Okay. So that's where, again, I'm sure your team is doing all the right things to try to.
Oh, they're great. They're like awesome. But I ask them so many questions. I think I asked the same ones. I was like, let me ask somebody else. Okay. All right, great. You answered my question.
Sure.
Okay. Thank you so much.
Yeah.
And your webinar was very, it was good. I knew a lot of the stuff, but I liked hearing the way you explained it very, very well. So thank you. Okay. All right. Sorry. Bye.
Thanks, Vicki. We have two questions coming through the chat. The first one, when the scarring happens, is that the place you try to replace for implant? My son has 30% scarring and no talk of transplant anymore.
Yeah, I'm not exactly sure what the team is trying to relay to you. If they mean 30%, there's some fibrosis in the liver, but the liver is draining. And what we mean by that is if the blood tests show that the bilirubin has normalized, the kids aren't showing any other signs of liver getting cranky, and that is cirrhosis and fibrosis, then that's when people start backing away from transplant because you really had a successful Kasai. And so the scarring is a process that we're trying to study in the lab, which is to try to figure out, okay, even if you have a successful Kasai, why do some patients still develop more and more cirrhosis or fibrosis in the liver? That's one of our newer models that we're trying to understand. And we don't know why it happens, but there are some kids who get a very successful Kasai, and then they're, like I said, in their teens, 20s living with their liver. And then we have other kids who also normalize their bilirubin, but they develop more scarring in late childhood, early adolescence, and then they have to be transplanted there. And so that's where the whole, biliary atresia is still a very strange diagnosis. And I've been trying to study it for a long time, and we still don't know what are the triggers that cause some of these changes. But we're also trying to figure out, and this is one of those things that families should have on their horizons, which is now teams are developing anti-fibrosis medications, and that could be a game changer, where if you have a successful Kasai and an anti-fibrotic agent is actually demonstrated to be effective, then we could keep kids going even longer without ever needing a liver transplant.
Thank you, Dr. Tiao. One more question that we had in the chat. Do you often see patients stay with their Kasai team for transplant or go to another hospital? How do we know the best spot for transplant?
So that's obviously a kind of a complicated question that I'm going to be very careful answering. So teams that, are, offering transplant are oftentimes very experienced teams. And, the information about how well teams are doing from a transplant outcomes is on UNOS. And so families can go to the UNOS website and get information as to outcomes for a center. But to say what's the best spot for transplant, it gets really complicated, right? You could have, some of the most effective living donor transplant programs are in the Far East. So, the idea that, a family could uproot and go to one of those centers, some families have the resources, they could do that, and they might think about it, but then they might have a center right down the street that does a great job, with deceased donors and, can help their kids navigate a recovery from that standpoint. And so that's where there's some, variability as to what is the best spot for transplant. Really, what is important is how your family is, together and what their resources are. Unfortunately, centers, most centers of excellence can have patients come from anywhere in the country. And so that's something that is, another kind of indicator as to a center's skill set. And so that's where, and insurance companies monitor those things. And so that's where there's a lot of moving targets to that. But of course, if you're, working with your team and they had a successful Kasai, then, they're, not all transplant centers are like ours where, it's, I did both pediatric surgery and transplant surgery. So I have the latitude of doing the Kasai, and then I'm still working with the families if, gosh forbid, the Kasai not working. And that does happen. And so that's where, teams the families are sometimes pretty comfortable with our team, but there are really effective teams where a pediatric surgery team is doing the Kasai, and then a transplant surgery team is working with them, and they're very cohesive and they make it work very effectively for their hospital and their institution. And so all of that is kind of it's not an easy answer. And this is where families have to explore, do due diligence, and centers are all willing to give second and third opinions, if families are going to have questions about what the outcomes are. And our job is to be as transparent as we can be.
That's great, thank you. We'll do one more question. I see a couple more coming into the chat. Dr. Tiao, could I email you these questions?
Sure.
Have you answer them that way? Great. So
real quick to Leslie's question. Yes, so unfortunately, pruritus is really one of the very frustrating symptoms that some kids will have. And yes, rifampin is very commonly used. There's some other agents that are being developed to try to address that. And so that is something that teams are aware of. Any kind of nutrition is good for a baby recovering from a Kasai. So they're good balance. You don't want to give excessive proteins, but you want to find a good balance. And this is where teams are working with most hepatology teams will have nutritional support contributors who are trying to help the kids optimize their nutrition, because that is one of the things that can help a liver recover. And that last question is a little more complicated, so I will answer that by email.
Go ahead. Great. Well, thank you so much.
I have one more question. If the doctor have time.
Sure.
So my baby is 8 months post Kasai, and her poops sometimes are not fully color. There are some white dots. I asked my team, but they answer it's not whole white, so it's good. I'm asking myself why sometimes are fully colored and they look very good, but often I can see that white dots.
Yeah, and that's where we ask, what I always encourage families to do is not ride the roller coaster of recovery. This is not right. This is not fair. But if you go up and down with every change in color of your child's poo, you will suffer a lot mentally, and it won't help your little person at all. I think generally, yes, kids will have some intermittent episodes where they have spots of white, but then as long as most of the poo has color, and then this is where if your little person is now 8 months out from the Kasai, this is when the lab tests are helpful. And if the bilirubin has normalized or has dropped, as I said, below 2, then you've had a successful Kasai. And then from there, you do exactly, like you try to, which is pay attention, but don't ride the ups and downs. If it all stays white for a day or two and the kids have fevers, then we need to hear from you right away. And that's when you get in the hospital, you get treated for cholangitis, and sometimes you get a short course of steroids. But if it's, one day, you have one poo that has a little bit white, but then the other ones are mostly green, great, then you're still draining. And so that's where, like I said, the first few days, we're kind of really vigilant looking for the color of the poo, because that tells us the likelihood of a successful Kasai, is on the docket. If it doesn't turn white right off, if it doesn't turn green right off the docket, then you're headed to that trajectory of a patient who's going to end up needing to be transplanted in the first 2 years of life. Your little person is now 8 months out, and it sounds like he has some has pigmented stools. I think you can be cautiously hopeful that this will be long-term. But long-term does not mean forever, and that's where that's not fair. And down the road, the kids will have to think about it. Transplant.
Okay, thank you.
And I'd like to add, I'm Alan Durr, and I'm a board member of ALF, and also the father of my oldest son was born with biliary atresia. And I can say that we've gone through the Kasai. We had a living donor transplant for my son, and he is now he's now married. He went to college post Kasai, and he's now married and the father of 2 young boys who are healthy. So yeah, biliary atresia is a journey, but you go over each little hurdle at a time with the expert medical advice from our professionals to get the outcome. And I can, like I said, I can testify that post Kasai, biliary atresia, my son has come a long way, and it's been a journey. And there was a lot of bumps in the roads and ups and downs, but definitely with the help of our medical community, we were able to manage through it. And so now I'm a nice grandfather.
Good. I mean, that's, kind of you to share, and it's a lot for families to go through. But on the other side, and this is for all the families who are at earlier stages of this, the teams are there. This is not as maybe 25, 30 years ago when maybe your son was navigating this. There's a lot of things that have become much more standardized so that, kids can get care in their local regional areas in a way that can be pretty effective. But then, some families will want to explore other alternatives, and all the different medical teams are there to try to be supportive.
Thank you, Alan, for sharing that. Really quick, I just have a couple closing notes to get through. First, I want to say a huge thank you to Dr. Tiao for joining us today and for providing such a wonderful presentation. I also want to say a big thank you to Alyssa Rotterman, who is the program manager in the liver and intestinal transplant department at Cincinnati Children's, for her help in bringing today's program to life. So thank you. And only other reminder I have is that our September webinar will take place on Tuesday, September 20th at 5 p.m. Eastern Time. And the topic next month will be on the role of social work in pediatric care. We'll be joined by Hannah Huguet, who is a liver transplant social worker at Anna Robert H. Lurie Children's Hospital of Chicago. And for any nutrition questions, I saw one come in. Sneak peek, our October topic is on diet and nutrition. So we have that coming down the pipeline soon, which is very exciting. And I put in the chat, but if anyone has any other questions, I took note of one that I don't believe we got to today, and we will email about that. But anyone else has any questions, please be sure to join the Facebook group, ask your questions in there, get answers from other parents, caregivers. We really want you guys to use the Facebook group as a resource and to connect with other, patients and caregivers. So thank you all for joining us. I hope you have a great evening. Thank you again, Dr. Tiao. Take care, everyone.